everybody. Richard Clippen here. Very warm welcome to FSC Connect for Tuesday, the 9th of April. This, for many of you know, is the FSC's platform, which we started way back in COVID as a way to connect the community together, to take a look at the big issues of the day, and to invite experts from across New Zealand and across the region to share their insights and their expertise with us. And today is no different. Today is in part around diving into the topic around the social health crisis, but it's also about taking the cue from International Health Day, which actually was on Sunday, and starting to explore and to unpack some of the key issues facing New Zealand in terms of healthcare. But of course, healthcare is not just about healthcare. It's about much more than that. And we're obviously going to dive into some of that conversation. In terms of today's panel, we're delighted to welcome Rob Campbell, Louise Zacest, and David Bishop. I'm not going to introduce any of the panelists just right now. I'm going to invite them to introduce themselves in a moment. But many of you will know that the FSC has, for the last number of years, been doing lots and lots of research on all issues pertaining to our sector and how it impacts New Zealand. And one of the things we wanted to do today was to just dip into some of the health data and to give you a bit of a sense of perspective about some of the key triggers and some of the key issues that kind of feed into the broader topic around the social healthcare crisis. So in terms of the order of today, I'm going to invite David Bishop in just a moment to say a few words, just unpack some of the research for us. David will be 5 to 10 minutes, and then we'll come back to the panel and start to unpack some of the research, but also some of the broader discussion. So with that, thank you all of you for joining us, and a very big welcome to David, who is research lead for the FSC and has been part of the FSC team and community now for a number of years. Kia ora, David, over to you.
Kia ora. Thanks, Richard, and hi, everyone. Yeah, we're just going to have a quick flow through a bit of this insight and trends report. We have been, as Richard noted, researching the industry for around about the last sort of 6 years, 7 years, and certainly from 2020, we've started to do what we call our regular financial resilience index and our money and news series. So this is slightly different. This is where we're taking a big deep dive into some of the trends and data of the FSC holds, and then having a look around globally what's happening and what particularly is happening in New Zealand, in this case around social healthcare. It links very closely to our policy priorities. So for those of you that are within the FSC, you will recall our blueprint for growth. And one of those areas is ensuring that Kiwis have accessible and affordable healthcare. And it's one of the reasons for this report. The research report is based on an insight and trends into social healthcare. Moving on to the next slide. The reason around that is around World Health Day. So the World Health Organization, as Richard mentioned, celebrated World Health Day on Sunday. It's the closest day we could get to that. The theme for My Health Day, the World Health Day 2024 is My Health, My Right. And really what the World Health Organization, or who are trying to achieve, is to champion the right of everybody everywhere to have access to health services and other areas like education, safe drinking water, clean air, good nutrition. So it's a really important focus on ensuring people's health. And of course, that perhaps doesn't necessarily always sound like New Zealand. New Zealand's quite developed compared to other countries, and so. But the idea of quality, safe drinking water, clean air, good nutrition perhaps doesn't quite sit within New Zealand, but I think it does. And there are challenges globally and country by country into driving that aim. So we're just going to have a look then into our research and the research that we undertake. Really, this idea of this social healthcare crisis comes from this idea that globally we're all living longer. I think most people on the webinar kind of have an understanding of that, but actually it's actually quite significant. If we look back into the sort of 1960s, we're living around 11 years longer than that in New Zealand, particularly. So now an average of 82 years old in with the 2021 figures, and that's kind of a difference between 6 years of lifespan after retirement in 1960 compared with now 17 in 2021, and that's accelerating as well. And research suggests that there's another 45 billion years in addition on average for lifespan over a 10-year period. Then that equates to about an average of 6 more years per person. So the kind of acceleration, the growth and ongoing acceleration is really important when we think about how we're going to retire and are we going to retire well and our health through that period. If we combine that acceleration with the aging population in New Zealand, and it's expected to double the amount of 65-year-olds in 2050, we really start to sort of see the issue. People are living for longer, and there's more of us living for longer. So how do we cope as more people are living longer in retirement? And significantly, this significantly increased lifespan in retirement needs to be paid for somehow or funded, whether that's from the social system through NZ Super in terms of retirement, or health in terms of our health care, or indeed if that's personal or a combination of the two. So if Kiwis are going to live a dignified retirement, we really need to start thinking about how we're going to tackle some of these issues. We talk about lifespan, I just spoke about lifespan, but really what we're now sort of talking around is this idea of health span. So lifespan's how long we live in our retirement. If we look through the health lens, which is very much what this research is trying to achieve, we're looking at a health span, and although our length of time of retirement is increasing, the time of that in good health isn't improving at the same rate. And so, indeed, research by McKinsey has seen that as the pace of lifespan has increased or speeds up, we aren't seeing an equal improvement in our health span, so the quality of our health in those extended years. And it indicates that sort of we're living half our lives in moderate to poor health, and that hasn't really changed in the last 50 years, which is very different from the lifespan conversation. So, we know that health can be affected by physical and social environments and other socioeconomic status, but there's no typical older person, and health needs are different for different people. And mostly the research that we've undertaken, most of the concerning health issues reported in 2023, especially for younger generations, but is mental health, and that's definitely increasing. But cancer, diabetes, heart disease, and other non-communicable diseases like stroke and lung disease and disability affect the quality, definitely, certainly, of older life, or life for older people. So that means that we're going to be less productive, and as we're looking to fund our retirement, we might want to work more. We might not be able to because of our health spans aren't seeing that increased healthcare, and we're probably going to require more from the healthcare system in some way. So perhaps it's a double, or if there's such a thing, a triple-edged sword, and we're living longer. More of us are headed to 65 plus, and we need more from the healthcare system if we don't start to think differently and improve our health spans. That all sounds like doom and gloom. It's not really intended to. It's around sparking a conversation, and we're starting from a good place. In OECD data, 86% of Kiwis report good health, and that's much, much higher than the average of 68% across the OECD data. We do have an established social healthcare system, and we do have an established private healthcare system which supports and contributes to the health and well-being of New Zealanders, certainly funding around half of elective surgery through the range of insurances. And certainly, in terms of why people might be taking out insurance. So we've seen those numbers grow over the last year to 1.45 million, up to about 37% of New Zealanders have taken out health insurance, and that's to drive peace of mind. It's to reduce stress, especially through difficult family health events, and also financial consequences of health issues. So, it follows an increase globally. New Zealand is not an outlier in that sense. That lots of places have increased health insurance coverage, but certainly if we look at where we are now, we're not in a bad place. It's about making sure that we keep moving forward. And just to close off, really, this idea that older people have such a significant part to play in society, and health is such an important factor for aging people to be able to do so. And I think, from this research, we can really start thinking about healthcare and kind of create a well-balanced, integrated health system, and by focusing across all the different people working within the healthcare industry and collaborating to do better, really, and to help us perhaps avoid a looming social healthcare crisis. So that's just a little input into the research, what we found, and I'll hand over back to you, Richard.
Thank you, David, and very warm welcome to Rob Campbell, Chancellor of AUT, and to Louise Zacest, CEO of UniMed. Folks, this part of the discussion is completely interactive. Those of you who've been to our FSC Connects will know that the Q&A button and the chat button are there to interact. If you have a question or comment or a statement, please feel free to use that. I did want to invite Louise first, just to introduce herself. And perhaps, Louise, the first question to ask, is there a social healthcare crisis? And if so, what are some of the pressure points or evidence points of that?
So, hello everyone, I'm Louise Zacest, Chief Executive of UniMed. It's great to be here today to have a chat with everyone. And I have had the privilege of working across the health sector in New Zealand for 2 to 3 decades. I've been fortunate to work in the public sector as well as the private sector in healthcare delivery and in healthcare funding. So I guess that gives me a bit of a rounded view of the sector as a whole. And I think one of the things we talk about the public health sector and the private health sector, my view is there is one, and I really endorse the comments that were made earlier by David. We've got to really look at how we work together collaboratively. My perspective is that I think we have a health system that is under severe pressure, but I don't actually believe we have a system that's in crisis. If we don't act soon, we could end up with a system in crisis. And the reason that I say it's not in crisis is actually when you look at the statistics. So what I'm referencing is the OECD report on healthcare, the latest one, which is 2023, and we're only just into our 2024 year. And New Zealand is a very, very strong performer around health status. We are also a very strong performer around quality of care. And I think those things are critical when we're actually talking about things like lifespan. So where we do fall down versus the rest of the OECD at present is our cancer mortality rates are not good. And access to care, there are access to care issues. And one of the metrics that is used is waiting times for hip surgery, so orthopedic surgery. And, the stats are available online. If you are looking to have hips orthopedic surgery in this country through the public sector at the moment, you'll wait about 137 days. Our experience from the health insurance side of things at UniMed, it's about 75 days. So you can see there is a significant gap occurring, which is concerning. But there are lots of reasons around that, and we will start talking around those things. But if I could highlight one thing that I think is heading us towards crisis, is actually the state of our health workforce. And I have worked in community care. I sort of maintain contacts there, and talking with nurses that are delivering and doing health assessments, supporting support workers in the community who are the people who look after the elderly in the community. They are incredibly strained, and we also obviously see that in the health workforce. I met with a large healthcare provider group just last week, and they said our challenge is getting more doctors in the country. How are we going to do that? So I'll end there. I'm sure we'll talk about it a lot more as we progress. But over to you, Richard, and probably Rob.
Awesome. Thanks, Louise. Yeah, Rob, big welcome. Thanks for coming on our series of events. And same, if you could introduce yourself and just perhaps answer that question. Is there a crisis or not? And what are some of the key pressure points?
Yeah, kia ora, Richard, and kia ora tātou. I'm Rob Campbell. My background in this respect is in a number of areas. One is I was chair of Somerset Retirement Homes in the retirement and aged care industry for about a decade. I'm currently Chancellor at AUT, which is New Zealand's largest provider of training into the health sector, if one looks across all of the professions and activities that go into that sector. And I was chair of Te Whatu in its setting up stage. I'm still active in relation to a number of public health and social health issues in Tāmaki. So that's my background. This issue of crisis or not, I don't know that it alters what we do a heck of a lot. There are places which are in crisis. I think many parts of our health workforce certainly experience the current period as a crisis. I think that many parts of the public health system are undoubtedly in crisis. That should not obscure the fact that there's an enormous amount of not only good work but good results that takes place in our health service. So you can look at it two ways, I guess. I do think that the statistics, the average statistics that we all use for obvious reasons, often do obscure significant equity issues in access to health and outcomes to health that no occasion like this should ignore, and they do partly constitute part of the crisis that many people experience in the health sector. If I could just say one final point, that does elide pretty closely with what Louise was saying. I think one of the mistakes we make in discussions about health policy in this country is that we assume that we have a dominant public health system, and we don't. We have a system which is largely dominated by private providers, doctors, community sector providers, everything from midwives to dentists, you name it. Very often, most often, you will come in contact with a private operator. They may be funded by a government agency, but they're very often private providers. And so the really genuinely public part of our system ends up being a minority of what goes on. And I think that is something that we often forget. I think that public sector could be strengthened, but there is no answer to the various parts of the health system that are under stress or crisis, which doesn't include close integration of the private sector. Whether you like that or don't like it isn't really important. If we're going to deal with the sort of issues that we're now facing, we have to involve both parts and integrate their services to meet the needs of the community. So that's my perspective on it, Richard.
Thanks, Rob. Can we just maybe pick up that last point, in particular with you and Louise? Is there broad recognition that there is one sector that it's big in private, and that actually it has to work together to actually get those health outcomes? Is that a widely recognised truism, or would people sit around a table and actually debate that out, do you think?
Well, I think they would sit around the table and debate it in Molesworth Street, but that just tells you something about Molesworth Street more than about the sector. I don't think anyone who's actually working out in the sector is under any illusions about this. But a lot of our policymakers, I think, still act under the illusion that the public sector is the centrepiece of it all.
Yeah.
And look, I'd reinforce this. I actually think it's at a planning level where things are not joined up. And while this is, a couple of years ago, I think the experience still holds. When the bowel screening program was rolled out across New Zealand, the private insurance sector was not engaged. So what happens when, it's a fantastic program, public health program, but what happens when there is a need for further investigation identified through that? People who have private cover choose to have private colonoscopies, and if something then is identified and there's treatment required, and that can move on to surgery, there was just no recognition that if you come at this from a person perspective, from the healthcare consumer perspective, we need to be tying all these together. And the public sector, I guess government policy could have had a much stronger impact if there had been collaboration with private health providers, because we all would have been reinforcing the program. And I think that's where there is opportunity. I'm sure we'll get into some of the discussion. These are big issues that we're trying to solve here around increasing demand associated with ageing. And people consume most of their healthcare in the last 4 years of life. The McKinsey study shows that we're actually our latter years are not healthy years, we're sick. So we have to get in a situation where we are, as Rob says, working together, but also looking at doing things differently. I think it was Denning that said every system is perfectly designed to get the result it does. So we need a different approach if we want to get a different outcome.
Yeah, Richard, I adopt a very wide kind of view about what the private part of the health system is, because it does extend into those operators such as a local GP or a midwife or whatever. But when I observe what's going on in the health sector today, most of the positive change is happening in the private sector rather than in the public sector. And I mean that if you just look at things that are happening in the last recent months, you find that the private sector providers in primary care are starting to now say, look, actually, we can't wait for the public sector to get on to this. We're actually going to start forming new ways of doing things. And you find new initiatives taking place in that primary healthcare sector, that some of which are well known and some of which are just individual initiatives, but they add up to people taking initiative in their own rights. It's very, very obvious in the Māori sector. The Māori health sector is starting to initiate really quickly. Just this week, we've probably seen most people in the news media the announcement of some of the initiatives being taken by Whānanga and the Waipirera Trust people in South and West Auckland to provide different ways of providing health facilities and the broader kind of health services that an ageing population needs. And indeed, that makes the point that if you look at what has been done in aged care, it has nearly all been done by the private sector, the improvements in aged care that have been made, and it's not enough, it's far from enough, and it's far too limited to people who have equity in a home. But nevertheless, that is where the initiatives have taken place. And in the public sector, there has been an almost complete absence of progress in the issues of aged care, which is looming as a huge problem for the rest of the community who don't have those resources. So I think that particularly if one takes this broad view, I could go on, you could say the same for Pacific communities of which I'm aware where there are real initiatives going on, and they're really all happening because the public sector isn't providing for them. Now, this is not to have a hack at public servants. It's to do with resources, it's to do with planning, but critically it is about conceptualising health as a holistic thing and health services as holistic too, not simply as something that's provided by one agency.
If I can add to that, Rob, when we look at the hospital sector, the public sector, the government is capital constrained. And so what we are seeing is private hospitals are building capacity. They're in a position where they can build capacity faster than the public system, and they're doing that to meet their needs, but there is huge opportunity for some really good collaboration. And we see that in the Auckland market where there is collaboration around radiotherapy. So, joint development of a really state-of-the-art facility which does sit on a private provider's site, which is utilised for both public and privately funded patients. And it's models like that which can really shift the dial.
So this is really get me wrong, Richard. I'm talking here in a sense of realism. I personally would prefer that the public sector was much more active. I don't really accept that the public sector is nearly as capacity constrained as it believes it is. It has created a situation, and politicians have created a situation in which we are resource constrained. And there's also been a lack of policy understanding of where the effort ought to be put into. But things like the workforce gaps that we have, the training gaps that we have, the facilities gaps that we have, they're all things that could have been and should have been fixed by the public sector. It's not a matter of the public sector not being able to do this. It has deliberately chosen not to do it. And naturally, that gets filled by either the for-profit part of the sector or by the not-for-profit part of the sector that is outside of the public realm.
So really interesting conversation. My last one on this one, and I'm going to segue then into this capacity and capability discussion. Do you think this is a hangover from COVID, that the entire system kind of pivoted perhaps away from what it was is business as usual and kind of went into basically pandemic readiness and had to relearn a whole bunch of things which in some ways we're perhaps paying the price for, still paying the price for now?
Look, if I can, Louise, my view is that COVID exacerbated things, but these issues would have all been there, whether there was COVID or not, frankly. And I think it's a bit easy to use COVID as an excuse. All these things have been building for a period of time, not dealt with, and now we face it, and COVID certainly exacerbated it.
Yeah, and I would concur. If we look at what drives demand for healthcare services, it's the ageing population, it's the demographics, which has been, as per the presentation from David, that's very clear what's happening there. It's increasing technology, so the ability to do more, whether that's different pharmaceuticals or it's different kinds of technology, or it's the ability to deliver services remotely or virtually. And then there's increasing consumer expectations. So with the ability to do more, people want more. And so those are kind of the core drivers for demand. But on top of that, we've put COVID. From our perspective, looking at it from a health insurance perspective, there was definitely pent-up demand that came through. We think it's at the tail end of that, though. So I do think it had an impact. And I suppose as someone who was working within a DHB environment, and where we were in a situation where most, if not all, DHB throughout the country were hitting their targets that were in place prior to COVID, and then we're not able to afterwards. Something went wrong through that process, and we're struggling to recover from that. My personal view is something went wrong around the whole sort of clinical managerial partnership, which is so critical to delivering services. But then what you hear me talking about is hospital-based services. I concur with Rob that, most of the future is actually about what we do in the community, because it's about ageing population with long-term conditions and how do we drive something really different.
Awesome. I'm going to come back to that innovation and in the for-profit and the community sector. But Rob, can I just go back to that point you raised? And I'm going to bring in one of these questions from one of our delegates. The question is, why is our health system so unstable and underfunded? I moved back home 5 years ago from Australia where health insurance is reasonable, but here in New Zealand is terribly expensive and doesn't cover much. So I guess the question, Rob, to you first is the capacity and training discussion that you raised. Are we training enough people? Are we kind of managing our workforce, or is it the fact that across the ditch they're offering significant uplift in wages and they're cherry picking some of our talent?
Well, it's certainly true that we exist in, at best, a Australasian market for health sector skills, more likely a global market, frankly, for most health sector skills. So that, and New Zealand is a country that is relatively low pay, relatively so finds it hard to compete. And look, there's no argument about that. And I mean, there are people sitting in other countries who would say they had trouble competing with us too, which is something we have to remember as we take their trained health workers and put them into our system. So there's an unfortunate hierarchy there to some extent, but we do have training issues. I think we have occupational licensing issues in some parts of the sector where we could have more flexibility in the way we define jobs and the way we define appropriate training and the way in which we define workplace activity. I don't want to put too much burden on that, but I think it is part of the issue. I think we also, it's not just a matter of training places. One of the most disturbing things is the number of people who start training and then drop out because they economically can't afford to, either during the training period or, as is quite pressing and seeing a bit of publicity about at the moment, when they're trying to find placements and being able to finance their way through placements. So there's an issue about how we fund and approach training as well as the planning of that training across a number of the organisations. And again, the pay issues, everyone treats them as if they were some sort of a surprise that snuck up on people, but they weren't. The pay equity issues were very well known for a long period of time. The difference is stark one at the moment between pay in the public sector and pay in closely related private sector provision for many skills, medical technologists, nurses, a whole variety of skills. Those are issues that have been known about for a long time and should have been planned and organised for. So I don't think we do any part of that all that well, except that, going back to a point Louise made earlier, and we do have to emphasise this, the quality of the people we do train and the quality of the people that we employ is globally high. There's an issue with numbers and there's an issue with the way we get people there, but we do have highly skilled people working in the sector.
Thanks, Rob. Louise, your take on the topic?
Yeah, so I guess there was a question there about affordability and comparability with Australia. And the Australian system is quite different in that there is a community rated system there, so everyone pays the same price regardless of what age you are. Here it is, it's more of a rate for risk system, so people pay based on age, and obviously the older that you get, the more expensive insurance becomes. We also have lower penetration of health insurance in New Zealand, so we're sitting at around 30%. I haven't seen the Australian figures for a while, but it was about 45%. It did go above that. And there is a real incentive in Australia, so there's a carrot and stick approach. If you are over a certain income threshold and you don't have private insurance, you pay an extra Medicare levy. And if you do have health insurance, you get a tax rebate. So there are some things driving that behaviour. But we also need to come back and go, we're a country, of 5 million people, geographically spread. Some of our centres are very small, and therefore the ability to drive economies of scale impacts. And I think that impacts our health providers, which in turn, means we have probably higher cost of service, and perhaps perhaps the level of competition isn't what it is across the ditch, which also might drive some of that behaviour or some of that, let's call it the cost inflation that sits around there. But I know within our organisation, and talking to my colleagues that sit on the FSC Health Insurance CEOs Forum, that we're all struggling with surging claims inflation. Now, what that means is that people are needing to access their insurance more because they can't get access in ways they have previously, but also that the cost of care has gone up substantially. And those together create some real challenges around long-term affordability. I also put it in context. I have a daughter that lives in the US, very healthy young woman at university, pays $2,500 US a year for insurance. That would be 5 times what she would pay in New Zealand. And I think that's we are not used to paying for health insurance at high levels in New Zealand. And I think as we see more activity happening in the private sector, we're going to have to question some of those, historical perspectives.
Yeah, interesting.
Well, just it doesn't get as expensive as taking the dog to the vets. We'll be all right, Louise.
Louise, picking up that point. Yeah, having one of my kids down in Otago, in and amongst all the health science students, the rigor, the quality, it's very full on in terms of training. So, the people are coming out of that system are super competent, super well trained, and super committed, and obviously therefore in high demand. So kind of interesting. Hey, I just thought just a quick segue. David, I'm going to bring you in if I can. And this is kind of this relativity, because it's pretty easy to sit here in New Zealand and go, oh, perhaps woe is us, or maybe it's not as good as it could be, or maybe there is a crisis. But David, we're significantly higher compared to OECD data in terms of people's view on their own health, aren't we?
Yeah, totally. And I think Louise touched on it as well. But looking at the indicators from the OECD in 2023, things like smoking prevalence is a lot lower than the average. So I think it's about 9%, 9.5% compared to OECD levels of about 16%. Cleaner air or air pollution deaths are considerably much smaller than those the average of the OECD. I think it's like single figures versus nearly 30, an average of 30 in the OECD space. So yeah, so I think I think, like I said at the end, it's not all doom and gloom. We're in a good space, and I think Louise and Rob have reiterated those points. Right, it's about what we do now to prevent or to stop perhaps a bit of a slide. And certainly, when I was looking at global figures in terms of age, population, aging. For example, I think it was the UK has actually started to drop its average age in terms of life expectancy only by a year or two, but it's starting to be a bit significant. And I think unless we, start to look at how we can get probably a bit more preventative to make sure our health span or our time in retirement is more healthy, and also how we can deliver a more robust joint system. I think that's the challenge, and I think that's where we are now, and that's where we can start to make a real difference for the future.
Thanks, David. I'm going to just perhaps topic to explore then is, Louise, just picking up your point. If our usage of the healthcare system is most pronounced in our final years of life, and there's a whole bunch of discussion around getting older and life expectancy kind of expanding. Can you just unpack for us, Louise, how does that actually work in terms of people's ability to be resilient, the resources that they may have, the care that they may have, the money, the housing that they may have, and how that might kind of impact what their health experience looks like? You're currently on mute.
Sorry about that. I guess if we step back, if we look at healthcare services, the international analysis suggests that services only contribute 20% to actual health status. And so most of it is driven by factors, socioeconomic factors, basic things about housing. So we have to get those settings right. And I know, and I'm sure Rob will pick up on this given his experience working in the aged care sector. Traditionally, Kiwi families have had the family home, and then sold it at some point and that funds going into care, all of those sorts of things. But we have a population now that is renting, and I think that does create different dynamics as we move forward. Looking at the ageing population, very elderly people don't access a lot of elective services because they get too frail to do that. So the care that those people, the support those people need is actually community-based services around their long-term conditions, which is heart disease, congestive heart failure linked to that, it's diabetes, it's respiratory illness. And I think it is how we get a really joined up primary and community care sector to support those people effectively in the community, whether they choose to live with whānau, whether they choose to live in retirement villages, or whether they choose to live in their own homes.
Yeah,
thanks, Louise. Yeah, Rob.
Louise, I think at that aged care end, we have in New Zealand evolved a system, the mixed retirement village aged care structure, which provides, I know people will argue the toss on particular services, but generally provides a pretty good structure for aged people who are in a position to enter those environments. Our home care facilities and support and services are not as good even for those people, and so there's work to be done there. Equally, there's work to be done amongst those people who lack resources and who are living with whānau, but often the people who have to live in whānau are not, surprise, going to live with whānau in the best housing in the community. They're often going to live with whānau in the worst housing in the community. So there are real issues around that. And the other thing that we mustn't lose sight of, while the older important, and I'm up in that age group that shouldn't be alive. If we'd stuck with 1960, I wouldn't still be here. You might all think that's a good thing, but we've also got to look at the people at the other end. And I think our young people are another issue where we're not keeping up with what we need to do for people who have poor housing, poor nutrition, poor other social facilities available to them. And this flows through to the experience of young people, even right through their teenage years and into their working life. Our health system in that broadest sense, our public health system and our supportive social health system hasn't really kept pace with need in that area either. And you have to remember that is creating problems decades down the track, as well as the problems it's creating for those people now. So nobody really yet in the political sphere is dealing, I believe, with the importance of all of that. And a lot of that, if you've got to accept that, there's, I don't know, in any kind of society, there's a significant, hopefully minority portion of people who will not ensure their way out of these difficulties. There are a large proportion of people who will be able to ensure their way through these difficulties, and they should access that, and the system should be available and should accommodate it. But there are people whose income level is simply such that they won't be ensuring their way out of those problems.
Rob, just a quick follow on, and David, I'm just going to go to you on Tamariki and the data that's turning up about mental health in younger New Zealanders. Rob, is that where kind of the innovation, both for the very elderly, is coming in at a community level? Is that where you see the place for a lot of those community organisations?
Yeah, look, I think there is some. There's nowhere near enough, but I'm very impressed by some of the integrated housing and health care and social support work that's going on amongst Māori communities who get this and are not sticking with their old systems, but are moving to new systems suitable to their old people at the time. I don't think we're as good about that with young people, where it's a little bit more one size fits all, or often people don't even get the care at all. So the young people do worry me, and there's clearly a gap in mental health services, and this is outside of my sphere of expertise. Possibly a lot of this is, I'll try to avoid that, but in the mental health area, there's something that we're missing badly in teenage mental and spiritual health, early adult mental and spiritual health, that is going to cause us immense problems right now and further down the track. So we just need a whole lot more flexibility in the way we think about those things. And I do think there's innovation going on, but you know, it's far from enough at the present time.
Yeah.
And
Louise, you were just about to jump in.
Yeah, and Richard, it's if we talk about lifespan and we talk about people's health trajectory, you know, by the time people get to their 60s and 70s, they have conditions, and it's very, very difficult to change the trajectory for those people. But what we do have the opportunity to do is to really support our rangatahi and tamariki and look at how we can enable them to have a better health trajectory and to live not just longer, but also to live healthier. I know when I was working in South Auckland, we would have discussions that potentially we have a generation of young people who will actually live less long than their parents.
Yeah, because, sorry, Louise, you go.
No, you go, that's fine.
I was just going to pick up, you know, this notion. We talk within the FSC community about health span and lifespan, you know, which is a fairly complex thing to kind of understand. But and so maybe you can unpack that a bit for us. But the specific question is, in many ways, our kind of health span, how healthy we're going to be. We actually set that down early on in life, right? What we eat, what we do, who we hang with, habits, healthy habits, and so on, right?
Yeah, absolutely. You know, it is very much the social environment people are in. It's their schooling. It's just the social mores that are around it. It's having you know, you don't get respiratory illnesses if you live in a house that's warm when you're a kid. And, you know, one of the things in South Auckland, it has got the highest incidence of bronchiectasis. Probably haven't said that properly, which essentially is inflammation of the tiny, tiny, tiny little bits that are in the lungs. And it's, you know, it tracks back to living in environments which are damp, overcrowded, potentially with smoking, and, you know, so you basically have little lungs that are damaged, and then over time, those people, as they, you know, as they age, become more at risk of developing other conditions. So I think I think Rob's put a challenge on the table, which is we really need to look at how we support our young people better. And I think as a sector, if we can get actively engaged in prevention activities, support for young people and also for working age people, we will have better long-term health outcomes for New Zealanders.
Awesome, thank you. Hey, David, I was just going to go
Richard,
to you.
I wonder if I can just touch very quickly on one.
Yeah, sure, you go, Rob. You go.
One other part of this healthy lives thing, which is really important in my view, but is often overlooked. I think that the stress that is being imposed on large parts of the health system now is a stress, the cost of which is largely being met by people working in the health system. And I think that the stress and ill health that results from that stress amongst our health workforce is a real issue for us. And that people working in the health system across the board really have to be aware of that, because when people are working under the kind of pressure that many are, with the sort of issues that they're dealing with, the pressures just of the nature of the relationships they're having with people, I think we underestimate the health impacts on staff and what that does to them, partly because they often leave the job because of it, but also because of the impact it's having on themselves and their whānau. It's a real issue in this sector at the moment, in my opinion, which we overlook at our peril.
Yeah, thank you for that, because that goes to the heart of your workplace resourcing, and I guess once you've left the system, it might be hard to come back, right?
Mm.
David, can I just head to you just briefly for your take through the research on, what really was impacting on younger New Zealanders? We've done lots of other research through FRI and other things, but how did it show up in this data in terms of some of the big issues facing younger Kiwis?
Yeah, sure. I mean, I think there's two, and very much Louise and Rob have touched on them. The first one is around this equity and home ownership piece. Much more younger people aren't owning their homes, and we've just been out in the field for our next round of research, and what's come out of that right now, or what's come out of that in terms of the stats, is that for non-homeowners, 60% are saying just even meeting their living expenses day to day in this current economic environment is really, really tough. So this idea of being able to rely back on a home to fund retirement is probably getting farther and further away if we look at stats like that. And the other one really is the mental health piece. And overall, within our financial resilience index, we look at physical health, mental health, relationships, and then overall holistic well-being. And without a shadow of doubt, younger and especially younger women are most affected by mental health worries. And in fact, it's the biggest worry health-wise from the research that we do. And I would say that, although maybe, since we've been doing this since 2020 when COVID was coming over the hill, I think, we saw a little dip actually in through the COVID time in some of these areas, but certainly from 2022 right up to the research that's just got back in from a field in the last week, we're jumping mental health, financial issues affecting mental health in this instance is risen from about 50% to 60% over the last 2 years. So it's something, to Rob's point and Louise's point, that's definitely not going away. And the support and how we help all New Zealanders, but particularly in younger space, to actually sort of manage this as one of their biggest concerns is really important.
Thanks, David. Folks, it's 4:21. We've got time for two last topics. Really nice question here. Thank you. I'll just read it out. Talking about health trajectory, 1 in 3 adults and 1 in 8 kids are obese. The WHO predicts that 50% of the world's population will be obese by 2035, which is obviously going to have significant impact. How do we tackle this issue? Rob, maybe start with you. Or Louise, start.
You go, Rob.
Who wants the conch?
Pick me out as the fattest guy on the on the program. Look, obesity is a real issue, not just because of itself, but because of the comorbidities that go with it. Some before and some after, but comorbidities are still whether they came first or second. So it's a real problem, and it's a growing problem. My view is that we are focusing too much on treating the outcomes of those comorbidities and not enough on the causes of them. And that sounds a bit harsh, because if you need bariatric surgery or you need a limb removed because of your diabetes is advanced so far, well, you need it. But it's not the answer, and we're just generating more and more people with those severe problems. So the issues there are nutrition, activity, housing, and other forms of social support. So I'm pretty involved with programs, but there are others around the country run by the ones I'm involved with, are run by David Ateli and his team at BBM. Program called From the Couch, which is now a collaboration with one of the private sector providers. So that's the sort of thing I'm talking about, because the public system as such just isn't responding to and dealing with those situations adequately. I personally think things like healthy school lunches are an important part of that, if that's one of the only experiences people get often of healthy food when they're young. That's a problem, and you have to take a holistic approach. It has to be community and whānau based, and we'd simply have to do more in that area. Everyone in public health knows this to be a fact. There is not a contrary viewpoint on this, frankly, that I'm aware of. You can't find it. And that reflects the general thing. If I could just quickly comment on one of the very good things we have in New Zealand is we do have excellent public health and other health research, and very good public health and other health information. What happens is that the system sometimes doesn't respond quickly enough to it. and introduce the kind of things that we know we should be doing. So in obesity, I think we basically know what we should do. I think it's not high tech, and that it's simply a matter of lack of political will to get on with it.
Thanks, Rob. Louise?
We do have an obesity issue in New Zealand, and again, you look at the OECD stats, we are at the upper end in terms of the percentage of our population that is obese. We also have childhood obesity, going back to that issue of what does the trajectory look like for young people. I concur with Rob. We have fantastic public health expertise in this country, and it is just a matter of doing stuff. And I was thinking while Rob was speaking that actually perhaps from an FSC perspective, that may be something that we may want to proactively look at because, between us, we touch a lot of New Zealanders. We touch 1 in 3 New Zealanders. So, and if we take the community view, if you start driving social change in one group, and then you look at how you spread that change. And, these are issues that iwi are grappling with too, because there is higher incidence of, and Pacific communities, because there is higher incidence of obesity within those communities. And look, that reflects a whole lot of genetics and history and, complexity. But this is the opportunity to actually perhaps, in amongst all this discussion of crisis, actually pull out something that if we all tackle together, we can make a material impact.
Thank you, Louise. Hey, folks, I'm going to just close this out with just some really great questions here. We're not going to have time, folks, but really great question here. Does social support need a new hard approach as per the David Seymour view of the world, suggesting fines for not attending school, do the same with known junk foods, etc.? So there's a thought there. There's a piece here around the portability between private health insurers is a good question. And there's also just back to the very beginning of this discussion about how we support the public, the private and community sectors together. So I really thank you all for your questions. I thank the panel for their insights. I'm going to ask them one last question to close out in 30 seconds or less. If we're sitting here in 7 years' time, Rob, Louise and David, what does it look like? What is this perhaps question? Has this crisis been averted? Have we actually solved for a lot of the issues we've just raised today? I'm maybe if I start with you.
It'll probably be a miracle if I'm still here in 7 years, to be honest. I'm aging, no matter what the David's stats say, I'm aging fast enough. But look, I do believe that we can do things around all of our health services, but if we could dramatically improve our public health services in the widest sense of community health provision at all ages, that would be the thing that I'd regard as real success.
Brilliant. Thank you. Louise?
I think it's really complex. I think it is hard to change. I think it's very hard to change. And the issues that we're experiencing here are not alone in New Zealand. There are issues facing the rest of the developed world, and obviously the developing world has got their own set of issues. I would hope that we look back in 7 years' time and we actually see that we have a joined up system, that the settings are right for collaboration. And one of the preparatory questions you threw at us was around innovation. And as demand grows, we are going to have to do more self-care. Whānau and community are going to have to do more to look after people. And I believe technology could provide some significant enablers over the next 7 years. The question is, will we grasp them?
Amazing. I think there's probably a whole webinar on tech and innovation, and we might look to do that. David, last word to you on this one. Where are we going to be in 7 years?
Yeah, I mean, for me, it would just be the idea of collaborating, no matter the government, no matter which colour is in government in terms of National, Labour or Green or Maori, just actually working together for the longer term view rather than perhaps a more politically based shorter term view, I think would be an amazing leap forward, working with industry and starting to collaborate. And to Louise's point, we're not on our own. This is a global issue and we can do something to fix it.
Amazing. Thank you all. To the audience who have been with us, thank you for your questions. We have recorded today, so this will go up on the FSC's YouTube channel shortly. On behalf of all of us here, to the panelists, Rob, Louise and David, a big virtual round of applause. So thank you very much. Very briefly, quick ad from the FSC. FSC conference is coming up early September. We have just released the report that we have been talking about today, which will be up online. And if you'd like to come to the conference and you want to get access to some special pricing, have a look on the FSC website. We'll be sometime with you shortly. On behalf of all of us here on this webinar and the whole FSC team, thanks for taking the time. Have a great afternoon and see you on FSC Connect next time. Ciao. Bye for now.